what proportion of all patients with diabetes, all comers, actually have an A1C greater than 7%, Rosemarie?
Roughly speaking, it's 50% are a goal, 50% are not, meaning by ADA definition, an A1C higher than 7.
Well, now, that was all comers.
Right.
How many of these are newly diagnosed? And how many of that group with an AIC greater than 7% is already on therapy, 1, 2, 3 drugs?
I would say probably the vast majority who are not at goal are the ones who have had diabetes, long duration of diabetes, multiple agents. And we know that part of the problem is the lack of intensification as needed. Even in this country, it takes several years to add agents and to intensify diabetes treatment. I would say it varies significantly. Sometimes I have a patient who's newly diagnosed, and the impact of receiving the diagnosis of having diabetes gets them involved with lifestyle interventions, medication, whatever is needed to normalize blood sugar, because the impact is significant for them.
You know, that's counterintuitive to me. I would have thought that the majority of the folks with AICs greater than 7 would be newly diagnosed, new to the office, new to the disease, and you're telling me it's not.
It varies significantly, actually. Sometimes people who tend to be on top of their health tend to be diagnosed at lower A1Cs because they transition from pre-DM to diabetes. Obviously, depending on access to health care, you may find a newly diagnosed with an A1C higher than 14, because that's pretty much
That's scary.
It is very scary.
And that's part of the problem. When you come in with a high A1C, like 10 or 12, which is often what we'll see, is that by starting them on one drug, you're not going to get to go. And particularly these people tend to be glucotoxic. So you really need to get the blood sugar down under control so the oral agents will work.
But Dr. Watson over here was after you to do this. More intensively, if you will. You were after one little control at a time, and you said, throw the meatball at him.
Right.
No, okay, I don't think we're saying vastly different things. I think
Sounds like that to me.
We're not going to ignore. I don't think he disagrees with me. If this blood pressure is out of control and
I
the
don't.
lipids are out of control, you're going to still start the statin and the ACE inhibitor, right? But what he's saying, and I totally agree with, is we're not going to say, and 10-pound weight loss by next week, and I want you to start, going to the gym 30 minutes a day. We're going to introduce all of these things gradually. I think the easier things actually are the medications. The harder things are getting them to change
But he
behaviors.
did say that if your A1C is 14, it's not likely you're going to get controlled with one drug,
I agree.
right? So why not start 2 de novo?
No, you would, and I think. Thank you for speaking for me, Carol. No, but she's right. What I was saying exactly, that is not overwhelming the patient, but the patient also needs to see some success. If they've got an A1C of 14, you put them on metformin, they come back 2 months later and they're 13, that's not success.
Right.
So I want them to actually know they're making a difference, and they'll feel better. The thing is, you're at A1C of 14, they think that's the way they should feel. Once their A1C gets under control, they will feel better overall.
But I think people have to translate, the hemoglobin A1C of 14%, where you need to be very aggressive, multiple agents up front. That's sort of like showing up to the doctor's office with a blood pressure of 200 over 110. That's not a patient that you should start a low dose of an antihypertensive and see them again in 6 months. That's a big red flag. Those patients, they're toxic from their hypertension, toxic from their glucose. They need aggressive management, likely multiple medications. And then once you control that to a reasonable level, I think then you could start to focus and fine-tune the rest of their risk factors.
Absolutely, and that's what I meant when I said I don't think we need to prioritize.
Right.
Obviously, if that same individual who has an A1C of 14 has a blood pressure of 200 over 100, guess what? We're going to be managing both.
How about a stay in the hospital with me?
Right.
And exactly what you said, and you say, people don't realize how they're not quite feeling well. Like their blood pressure is 160 all the time. You get it under control, and they're like, wow, I thought I had migraines, but my headaches are gone. Just like the glucose, they're going to feel better, and eventually that will translate into really motivation to continue therapy.
For the AICs over 7, what are the common comorbidities that you see?
I would say probably we're talking about type 2 diabetes. So the usual comorbidities that accompany type 2, 80% of our patients are overweight, dyslipidemia, high blood pressure. Obviously, something that we can modify, the patients can modify, is their smoking status. And we could obviously start interventions to target all these comorbidities that add to their cardiovascular risk.
And that's part of the problem is that patients they have multiple comorbidities and they're on multiple medications. I think for one of the practices I work, which is predominantly is a Medicare HMO, these patients are on average of 8 medicines. And and they're the healthy ones. So you have a situation where patients either can't remember, they can't afford, or they're basically overwhelmed by it. So working with all that, so you are trying to manage all of this, but recognizing the patients in the middle of that.
And that's again patient-centric. Human frailty, human physiology, human nature comes into play here.